A very good morning to all of you. So I welcome you all to the third edition of the RADV, and we are going to begin with the residence case competition. Our first case is going to be by Dr. Abir Al-Falahi, who will speak about the silent destroyer. Dr. Abir.
Assalamu alaikum. Good morning, everyone. This is Abir Al-Falahi, dermatology resident, Oman Medical Specialty Board. The silent destroyer is the topic that we are going to start our day with. So this is my agenda, and here we go. Starting with this patient, imagine with me a 65 years old male presented in the clinic, average height, normal build, medium dark skin tone, requested to follow up regarding his skin condition that he used to follow up in our clinic from 2008 to 2016. Then he stopped by himself by the next 7 years as he improved. But I was not bothered regarding his skin condition. Thus, I asked surprisingly, what happened to your left ear? And the shocked answer was, well, it has been here since 1 year. It doesn't bother me. It started as swelling, edema, and a small wound. Then, and I'm in regular dressing. And recently I was taking a shower and the lower half of it fell off. Huh? That was my facial expression. And the journey began. So here's a known case of pemphigus vulgaris, hypertension, diabetes, dyslipidemia, in his regular medication of his chronic condition, truck driver, and no recent travel history. He had old hyperpigmented biliaceous macules all over the body, head, neck, trunk, less in the extremities, sparing oral mucosa. On local examination, the left ear was edematous, hyperpigmented. Ulcer was mainly at the tragus and concha, and with exposed cartilage, and the lower lobe were lost. So this was my initial differential diagnosis. So a swab was taken from this patient. He had serous discharge, which turned to be negative only colonization. Next, slit skin test was done for this patient to rule out leprosy, which was negative, and an ear biopsy, skin biopsy, was taken from this patient and turned to be skin with infiltrative basiloid neoplasm and a high-power focal basiloid palisading of tumor cells, and immune stain turned to be for positive, which is favoring basosquamous cell carcinoma. Next, patient was planned for head CT and showed it was highlighted on the left parotid lymph node, and fine needle aspiration was taken from this patient, which turned to be squamous cell carcinoma metastasis. Thus, the basosquamous carcinoma was the diagnosis of this patient. Currently, patient is on radiotherapy. Moving on, so basosquamous cell carcinoma is a mixture of BCC and SCC, and it has a low incidence of less than 2%, and it's aggressive type of basal squamous cell carcinoma, which is even more aggressive than SCC itself, and it's mainly seen in the aerodigestive tract. And only 2 cases reported about these cases, specifically in the external ear. So basosquamous cell carcinoma and pemphigus vulgaris, is it a coincidence or something beyond that? So in this beautiful article, which discussed and summarized all the researches about about role of desmoglein and cancer, and it seemed desmoglein role is not only in cell-to-cell adhesion, but also in cell signaling, which was further supported by this article, which showed that not specifically in beta-catenin and 1 signaling pathway, where pemphigus vulgaris antibody tend to accelerate keratinocyte proliferation and differentiation. So whom to blame? Most researchers are with pemphigus vulgaris associated with internal malignancies. Recent model studies showed that UVB-induced squamous cell carcinoma did not tend to progress in desmoglein, in functional desmoglein, but tend to progress further and metastasize in dysfunctional desmoglein. Aha, so that's a wrap. Remember our patient? So we can conclude that in chronic UVB exposure, the main driver is the main driver for the squamous cell carcinoma, and further, keep in mind the background of pemphigus vulgaris is the promoter for further metastasis. Thus, pemphigus vulgaris is actually not completely innocent in our case. Thank you.
Assalamu alaikum and good morning, everyone. Just a mild correction, I'm actually from Oman, and we are all brothers in the Gulf countries.
Sorry.
So, microneedling along topical fluorouracil in the treatment of stable resistant vitiligo. Is this the way out? Well, I believe, as well as this patient who is 13 years old, this is my patient 0 and his family, we think it might be. So this patient presented to me with this big patch, and he's been suffering from vitiligo for years. He was even getting bullied at school. He tried multiple treatments modality without any improvement. This is when I first saw him. This is after 6 weeks, which is after only 2 sessions of microneedling along topical 5-fluorouracil. And this is after 10 weeks. They were very happy about the results. So, what is vitiligo? I'm not here to teach you about vitiligo. It is a nightmare. It is a well-known nightmare for both dermatologists as well as patients. And there are some different modalities to treating vitiligo. But due to the versatility in the results that we're getting, yet emerged a unique way for treatment of vitiligo to be emerged. So what was the aim of this study? The aim of this study is to study the effectiveness and safety as well of microneedling with a derma roller 560 titanium needles with topical 5-fluorouracil in the treatment of stable resistant vitiligo. According to the statistics, of course, the percentage of prevalence of vitiligo worldwide is ranging between 0.5 to 2%. It is about 2.18% in Oman. We concluded that 28 patients, given to the statistical methods, needed to be included in the studies. We were successful to include 13 patients of the 28 patients. So, of course, there were some specific criteria into including those patients. Those who failed treatment for more than 3 months, had stable vitiligo for at least 3 months, and of course, as any other cosmetic procedure, we try to avoid it in pregnancy or breastfeeding. So consents were given. What we did exactly, we anesthetized the area with topical anesthesia, with amla cream, and then we do the microneedling as shown in the picture there with a derma roller 520 titanium needles, and then we spray the 5-fluorouracil, which is at a concentration of 50 milligram per ml, and we do this at a frequency of once every 2 weeks. This is the procedure going on. So the data out of the patients that we are having, which were the minimum age of 13 years age and the maximum was 53 years age, including both males and females, we had sites of vitiligo, including at the first position we have the face and the neck, secondly mostly to the trunk, and we included some patients having in the limbs and the scalp as well. How did we grade the results? We graded the results G1, anything less than 25%, which is basically insignificant. Grade 2, between 25 to 50% repigmentation. Grade 3, between 50% and 75% repigmentation. And anything more than 75 repigmentation is considered as grade 4. At the end of 2 weeks, only after 1 session, surprisingly though, we got 7% having more than 75 repigmentation. And just to remind you, this is a patient who failed treatment for 3 months. Only 15 though, we had grade 2, but after 2 sessions, only after 2 weeks, we got 46%, so almost 30% increase. And according to the McNormal broker test, there was actually a significant repigmentation between week 2 and week 4. This is one of the 7% that I spoke about. So, just in short, why microneedling? Why topical 5-fuel reversal for the treatment of SABE-resistant vitiligo? Well, of course, it was tried, the topical 5-fuel reversal for treatment of superficial basal cell carcinoma, squamous cell carcinoma, and the side effect was hyperpigmentation. So microneedling by itself, it may induce the follicular melanocytes to migrate to the superficial layers of the skin and induce hyperpigmentation. Microneedling will help for the transcutaneous absorption of the drug itself. Of course, there are some limitations and some strength. What is the strength of the study? It is the first positive study conducted regionally using a derma roller. It was conducted only once worldwide in India, but instead of derma roller, they used the 26-gauge needle. It is safe and tolerable technique, does not require much experience, very easy to do it in the clinic. Limitations, we are limited by the small sample size, of course, and the short follow-up of the period. So in conclusion, given the limitations of the study, is this worth the try? Well, it is safe, it is effective, it does not require much experience. We had some good results in patients who are actually resistant to other modality of treatments, so why not to do it? Thank you.
Thank you, Dr. Ahmed.
Hi, good morning everyone. Today I'll be presenting a very common condition that we see in our dermatology clinics every day, but with an extremely important comorbidity that we need to pay attention to. So I'll be presenting a case of, sorry, this is not working. Okay. So I'll be presenting a case of a 9-year-old Emirati male who presented with an itchy rash on the flexure since 1 week, associated with nasal congestion and rhinorrhea. He has a recurrent itchy rash that affects the face, flexures, and the arms and legs with the thighs since 2 years, and those lesions are usually treated with topical corticosteroids and emollients with great resolution. It's always associated with severe nasal congestion, frequent complaint of stress tightness, wheezing, and difficulty breathing. He also has recurrent abdominal symptoms with abdominal pain, regurgitation, requiring multiple hospitalization. Taking the history from the mother who just came in because she wanted to have a refill for her medication, he was diagnosed in other departments with asthma, allergic rhinitis, nasal polyposis, and eosinophilic esophagitis. Both his siblings as well have eosinophilic esophagitis, and as you see on the examination, he has mild flexural eczema with CLD-QI of 5, and the patient only scored 3 on one dimension, which was bullying in school that affected his psyche. His total IG was 3,106, and esophageal biopsy showed eosinophilic esophagitis affecting the upper, mid, and lower esophagus. So the diagnosis of the patient is pretty straightforward. The atopic dermatitis associated with asthma, allergic rhinitis, nasal polyposis, and eosinophilic esophagitis. However, the patient and the mother have been following up with multiple departments and multiple hospitals trying to seek the best treatment for the patient, and he's been treated with a lot of treatment. As you can see, topical inhaled corticosteroids, multiple courses of systemic corticosteroids, and this was quite a complex way of treating the patient, and he was not responding quite well to all those treatments. When I was assessing the patient, I found that our usual criteria are quite limited and tools quite limited in assessing those patients because it does not account for the comorbidities of the disease. It actually only accounts for the skin disease, and that is not the entire story for this patient. The DLQI does not affect, or CDLQI does not account for the psychological burden for the mother. So I decided to go with the health-related questionnaire, and it showed that the patient was in actually quite poor health. Most of the month he's been getting affected by the disease. He's not able to sleep. He's complaining of a lot of pulmonary and abdominal symptoms with anxiety and depression. And he's been suffering through this since 2 years. So the question was, should we start this patient on dupilumab or not? The problem with that is the age of the patient, as well as the fact that he has eosinophilic esophagitis. And this required quite an intensive DT approach with the patient. And us as dermatologists usually try to refer those patients to the department and let them take over. However, they were quite concerned about this patient starting him on dupilumab, particularly with the GI, as he was quite young and it was not approved. So after discussing with those patients, we decided to start the patient on dupilumab. And usually when we select the doses for dupilumab, we select the highest approved dose, rather than for any condition that he's been affected with. However, for this child, they decided to start with the lowest possible dose and then gradually increase that dosing. So they started him off with the atopic dermatitis dose of 400 milligrams subcutaneously as a loading dose and 200 every 2 weeks. He did get quite an improvement where his hospitalization, where he was going 4 times per month to the emergency department to remove the food impaction that he's been suffering with due to the esophagitis, to twice per month for the ER. This was still not a good way to treat this patient. So then we started him on 300 milligram every 2 weeks, improved a little bit better, and then we continued to every week according to the most recent studies that have been on esophagitis with the pediatric cases. His follow-up was actually quite well, and he had 0 hospitalizations in 6 months, which was the most important dimension for me, rather than the skin disease. His follow-up also became quite infrequent for the other departments, and the mother was quite happy. So I'm just here to discuss whether or not we should see eosinophilic esophagitis as part of the atopic march or not. And we all know that the atopic march is a stereotype progression from atopic dermatitis to food allergies, asthma, and allergic rhinitis. And chronic eosinophilic esophagitis is also a chronic allergic inflammatory disease. The prevalence is quite low, 20 to 50 in 100,000, and the complications are quite severe. It's also quite associated with food allergy, where 70% of the patient had multiple food allergies, particularly egg, fish, and milk. So my point in this case is that we need to actually take the lead, especially that we have a very, very long experience with treating patients with biological therapies. Thank you so much.
Assalamu alaikum, good morning. This is Alanki, dermatology resident from Oman Medical Specialty Board. Today, inshallah, I will give this talk about rare human and rare association. So here is my outline, and I will go to the case presentation. Here we have a 25-year-old female presented with multiple itchy babulous on her scalp of 6-month duration. It was associated with bleeding after scratching. There was no history of any systemic symptoms, no history of local trauma, and she was not on any medication. So in examination, there is multiple grouped erythematous papules and nodules located over her left temporo-occipital region. The systemic examination was unremarkable and there was no lymphadenopathy. So what will you think of? Given the vascular nature of this lesion, we generate differential diagnosis of biogenic granuloma, sarcoma, epithelioid hemangioendolymphoma, Kymora disease, and angiolymphohyperplasia with eosinophilia. So based on that, we sent a list of investigation and it all came like normal. And of course, we sent for biopsy. And the histopathology in this particular disease is really crucial. So going into the skin biopsy, there is a lobular proliferation is composed of variable size blood vessels surrounded by scattered inflammatory cells. And the lining epithelial cells show enlarged vesicular, nuclear, and vacuolated cytoplasm. And the surrounding inflammation is composed of lymphocyte and many eosinophils. And incidentally, there was a demonic smite found in this sebaceous duct. So the diagnosis came as angiolymphoid hyperplasia with eosinophilia associated with scalp pedicosis. The patient was treated with 10 sessions of cryotherapy and also twice daily application of topical metronidazole gel. And this picture of the patient after 7 weeks with remarkable improvement, and she was followed for 1 year and there was no signs of recurrence. So the ALHE, or what is called also epithelioid hemangioma, is a rare benign vasoproliferative tumor present as single or multiple with defined erythematous papules and nodules. Usually it localized to the head and neck area and most commonly around the ear. So in the ear itself, the post-auricular site is the most common site, but it can It can be found rarely in rare location. There is case report that they found it in the oral mucosa, and the colon, and in the penis. So the etiology and the pathogenesis of ALHA is not fully understood. There are many theories have been proposed in the literature, and the most commonly accepted one that it is a reactive vascular hyperplasia to many stimuli like trauma, high estrogen level, insect bite, infection like scabies and HIV. And up to our knowledge, this is the first case of ALHA associated with scalp dominicosis. The choice of treatment depends on the size, location, size, depth, and number of lesions. The management of ALHA is challenged due to high recurrence rate and the absence of randomized controlled trials. There are many treatment modalities have been suggested. The surgical one is the best modality of treatment due to less recurrence rate. The other modality treatments include intralesional topical systemic steroid, cryotherapy, radiotherapy, laser, and electrosurgery. Going into literature review, this is one case also, and there is ALHA lesion in the left temporal treated successfully with cryotherapy. Also here another lesion in the ear, also treated with cryotherapy. And here just ALHA lesion gathered from different case report just for eye training. Here another lesion in the face and other one in the earlobe. So the ALHA is a rare benign vasoproliferative tumor. There are no standard therapeutic approaches for ALHA, and the cryotherapy can be considered a safe, effective, easy modality of treatment. And the role of demonics might in the pathogenesis of ALHA should be considered in future researches. This is my references, and thank you.
Hi everyone, good morning. I have a really interesting case for your morning today, and I hope you like it. I wanted to mention that this was actually the first case I saw as my solo on-call in my first year residency, and it always stuck with me, and I hope at the end of the presentation it also gets stuck with you, as I really enjoyed unfolding it, and I hope you enjoy seeing it. So my presentation is titled Harmony in Chaos, and I hope with time you'll see why I titled that. So starting up, I had a 25-year-old Syrian male patient who came complaining of a 3-month history of a non-tender nodule that started in the inner right thigh, followed by bilateral upper limbs and the skull. He first noticed these nodules 3 months back before presenting to the emergency. It started, as I mentioned, in the inner right thigh, then spread throughout the body. Some nodules even began to ulcerate and began to become tender with time. He went to a private hospital to which he received antibiotics for 2 weeks, as well as a topical treatment, but with no improvement, so he came to the emergency. Associated factors include swelling of the throat, as well as difficulty in swallowing and night sweats, but he denied any fever or weight loss. As for the past medical and surgical, it was insignificant, and there was no family history of any similar symptoms or complaints or any other diseases or malignancies. He is a non-smoker, non-married, and lives with his aunt. Now moving on to his general examination, he was vitally stable, afebrile, but despite all that, he looked really unwell and kind of in severe pain. Moving on to dermatological examination, is he had multiple mixture of erythematous as well as skin-colored, smooth rounded nodules involving the face and neck, the scalp, the upper limbs, as well as the lower limbs and trunk. He also had a single large, firm, indurated, as well as fungating ulcer, measuring around 10 by 10 centimeter, located on the inner aspect of the right thigh, with a bloody crust and discharge. He also had palpable inguinal lymph nodes bilaterally. For the differentials, we had blastic plazacytoid dendritic cell neoplasm, as well as cutaneous B-cell lymphoma and cutaneous T-cell lymphoma, and lastly, acute myeloid leukemia. Now, for the investigations, obviously because of the discharge, we did a wound culture which showed heavy growth of Pseudomonas and Staph aureus. And biopsy was taken from two sites. Firstly, it showed dense diffuse lymphocytic infiltration in the papillary and reticular dermis with a grand zone and large atypical lymphocytes. In a more closer look, he had dense perivascular, periadnexal, and interstitial atypical lymphocytic infiltration in the dermis extending all the way down to the subcutis. Now, because of that, the biology result was consistent with cutaneous B-cell lymphoma, but there was no immunochemistry staining done. Now, later with that, this patient was taken over by the hematology team in our hospital for further investigations, including more immunohistochemistry. They actually did 15 more markers, pan-CT for the staging, CT brain in view of his dysphagia, and bone marrow aspiration and staging. With that, with the immunomarkers staining, it was positive for CD123, CD4, and CD56. Any guesses what it was? Blastic plasmacytoid dendritic cell neoplasm, although we were all thinking it was B-cell lymphoma. So the patient is currently going a multi-drug chemotherapy, including cyclophosphamide, vincristine sulfate, doxorubicin hydrochloride, methotrexate, and cytarabine and dexamethasone, as well as because of the culture positive, he was in the course of tazocine. Now let's have a small discussion together. So what is blastic plasmacytoid dendritic cell neoplasm? It is a rare hematological malignancy, but the most common manifestation is a cutaneous lesion. It can and cannot have a bone marrow involvement and leukemic dissemination. It's nice to know that it consists of a lymphoma and leukemia, like 2 in 1. It was previously known as a natural killer cell leukemia and lymphoma, and like we mentioned, it has positive immunohistochemical stain profile 4, 123, 4, and 5. Now, it represents a malignant proliferation of the plasmacytoid dendritic cell. What does these cells produce? They produce large amount of type 1 interferon, specifically interferon alpha. And they also express several toll-like receptors, including 7 and 9. Now, they usually have a good response to the chemotherapy, but because they will relapse more commonly and regularly, so they have a poor survival rate, usually 1 year or even less, sadly. I found only actually 2 case reports of this rare disease, and in both case reports, they highlighted the importance of having a blood test investigation. Now, you may notice I did not mention it because in our patient, there was actually nothing in his blood test. But in these 2 case reports, they were able to diagnose the patient with the blastic plasmacytoid dendritic cell neoplasm only by the blood tests, actually. Now, take-home message. The blastic plasmacytoid dendritic cell can go undiagnosed for a very long duration and can result in severe morbidity because the survival rate also is low. All physicians should adopt a non-stigmatizing approach attitude, whether it was a dermatologist or a hematologist or whoever was in this case, and the proper follow-up care for the control of this disease. Thank you so much. I hope you enjoyed it.
Good morning. Today our case is a case of a 74-year-old female patient. She's known to have a resistant hypertension and anemia. She underwent in 2022 a laminectomy and in 2018 bilateral carpal tunnel intervention. She was diagnosed with rheumatoid arthritis after consulting for numbness, pain, tingling in both hands 3 years ago, and she was started on methotrexate followed by leflunomide for 5 months with no improvement of her symptoms. She presented to our dermatology clinic for petechia and purpura. The patient reports 5-month symptoms of fatigue, weight loss, loss of appetite, easy bruising, tongue swelling, and painful mastication, with dysphonia, hoarseness, difficulty speaking, changes in the voice quality, and numbness in her fingers. On the clinical exam, we found an impressive macroglossia with multiple rubbery nodules and teeth indentation on the lateral border of the tongue. Also, we found bilateral symmetrical violaceous purpuric patches at the lip lines and the eyes, with palpable purpura and petechia over the abdomen. So as differential in front of this impressive macroglossia, we can give as differential TB, lymphangioma, amyloidosis, acromegaly, idiopathic muscular hypertrophy, Beckwith-Weidman syndrome. So in order to elaborate the diagnosis, an incisional biopsy was performed on the lateral border of the tongue. Hematoxylin and eosin stain showed benign squamous hyperplastic epithelium with a mild chronic subepithelial lymphocytic infiltrate and deposition of amorphous eosinophilic hyaline-like material in the connective subepithelial tissue. PAS staining was positive. Congo red staining showed a red color peach material with immunohistochemical staining with amyloid A antibody negative and Congo red staining with permanganate also negative. So we conclude that we have an AL type amyloidosis and we rule out an AAA type amyloidosis. So the patient was referred to the hematology department for systemic evaluation. Blood picture showed a normocytic anemia and an ESR of 56. Serum electrophoresis showed a peak of beta-2 chain with very high free light chain lambda. Bone marrow aspirate showed plasmocyte of more than 30%. Further workup with Doppler echography was negative and whole body PET scan was normal. But electromyography showed severe axonal and mixed polyneuropathy. So in face of this, we can conclude that we don't have a non-IgM MGUS since the plasma cells are more than 30%. We don't have a smoldering multiple myeloma since we found on biopsy deposits of amyloidosis. We don't have a multiple myeloma since it doesn't fit the criteria of multiple myeloma. We don't have an hypercalcemia, neither renal insufficiency nor anemia with hemoglobin less than 10, and we don't have bony lesions. So the patient fell on stage 2 of light chain amyloidosis. We started a treatment with daratumumab, dexamethasone, bortezomib, and cyclophosphamide. 2 weeks after treatment, we see that the free chain lambda came back to normal. And 7 months after treatment, the situation of the tongue is in amelioration, but it didn't go back to normal yet. So as we all know, amyloidosis is a challenging disease since many clinicians and pathologists only became aware of it through an unexpected pathology report. And the symptoms of the amyloidosis can mimic those of rheumatoid arthritis. So before giving a diagnosis of rheumatoid arthritis, we should pay attention that it may be an amyloidosis. So this is an algorithm for when and how to suspect oral amyloidosis. So in front of a patient who presents with slurred speech, macroglossia, teeth indentation of the lateral tongue, we should correlate with systemic findings such as proteinuria, hepatomegaly, abnormal cardiac function, and neuropathy. And we take a neural tissue biopsy to study it with the Congo red staining and hematoxylin and eosin. If it came back positive, we should correlate this with a broader spectrum of investigation. And thank you.
Good morning, everyone. I am Fatma Guidi, dermatology resident from Rashid Hospital. Today, I'm presenting a case of 2 siblings with palmoplantar keratoderma. Our patient is a 7-year-old Emirati boy presented to the clinic with pruritic, painful thickening on palms and soles since infancy. As per his mother, it started at the age of 1 month as redness and dryness on palms and soles. The lesions gradually became worse, and by the age of 7, the lesions became markedly thick. However, there was no hair or nails or mucous membrane involvement. His drugs and allergies histories were unremarkable. The medical history was positive for amblyopia, nystagmus, and poor vision on both eyes. For the family history, his younger brother also had the same dry lesions on palms and soles, and he is a child of first cousin consanguineous parents. For the developmental history, our patient had learning difficulty and poor attention. On examination, there is well demarcated psoriasiform erythematous plaques on his palms, soles, elbows, and knees. There was no hair or nail involvement. On examination of the oral cavity, the gums appear erythematous, inflamed, and enlarged. There was loss and mobility of teeth. And our patient was following up regularly in dental clinic as he had severe periodontitis and premature loss of teeth. We sent a skin biopsy, and the histopathology showed mild hyperplasia and hyperkeratosis and parakeratosis. With these clinical features, we started to suspect a genodermatosis. So we sent our patient and his younger brother to a pediatric genetic clinic for further workup. The family consists of consanguineous parents and 7 children, and genetic testing was done for the whole family, and it showed that 3 out of 7 children were affected with genetic diseases. However, neither the parents nor the 4 other children were affected. As a part of genetic workup, a brain CT scan was done, and it showed calcification in the choroid plexus area. To sum up, our patient had palmoplantar keratoderma, pyogenic skin infection, psoriasiform plaques on elbows and knees, intracranial calcification, periodontitis, and premature loss of teeth. So with all of these clinical features, what diagnosis comes to your mind? Yes, it's Papillon-Lefebvre syndrome, and the genetic testing of our patient showed a homozygous deletion of exons 3 to 7 of the cathepsin C gene. And according to the laboratory in Germany, this was the first time they detect such a mutation in their database. Genetic testing of his younger brother also showed a mutation in the cathepsin C gene, which confirmed the diagnosis of Papillon-Lefebvre syndrome. Genetic testing of his older brother showed a mutation in the NR2E3 gene, which confirmed the diagnosis of enhanced Escon syndrome, which is a very rare genetic disease characterized by retinal degeneration and vision loss. Surprisingly, our patient, the middle child, had a mutation on both cathepsin C gene and NR2E3 gene, which means he was unfortunate to have both of these syndromes, Papillon-Lefebvre syndrome and enhanced Escon syndrome. For the management, because our patient's initial presentation was suggestive of psoriasis, we started him on topical corticosteroid and keratolytics with little improvement. We then started him on oral acitretin, 0.5 milligram, 10 milligram daily, which showed a significant improvement. This is our patient after treatment with acitretin. You can see that there is a complete resolution of the lesions after only 16 weeks of treatment with acitretin. In conclusion, Papillon-Lefebvre syndrome is a rare genodermatosis characterized by palmoplantar keratoderma in association with periodontopathy, resulting in the loss of deciduous and permanent teeth. Other features of the syndrome include psoriasiform plaques on elbows and knees, intracranial calcifications, and pyogenic skin infections. A multidisciplinary approach of dermatology, dental, and genetic and pediatrics is important for the management of these patients. Take-home messages: Papillon-Lefebvre syndrome is a rare genodermatosis characterized by palmoplantar keratoderma, psoriasiform plaques on elbows and knees, periodontopathy, and intracranial calcification. It's inherited in an autosomal recessive manner and caused by mutation in cathepsin C gene, localized to chromosome 11q14. The palmoplantar keratoderma typically has its onset between the ages of 1 to 4 years. Oral retinoids have been reported to be beneficial in treating both the cutaneous and the periodontal disease in patients with Papillon-Lefebvre syndrome. Thank you for listening.
So good morning, everyone. So for today's talk, I will be presenting a rare case entitled What's in Your Head under the supervision of Dr. Rima Gammoudi. We have no conflict of interest. So it's the case of a 20-year-old man who presented with a 2-year history of multiple scalp nodules. The lesions initially started as painless localized swelling, which evolved progressively over 2 years into multiple scattered vegetative and ulcerated growth. He had no relevant medical history, no fever, no arthralgias, nor any systemic symptoms. He also denied any triggering factors such as infection, trauma, or drug exposure, or any recent travel. He had no family member with similar skin lesions and no known family history of skin cancer. There were no lesions elsewhere on the body, and the remaining physical exam was normal. So what are your differentials? I think it's important in front of such case to divide our differentials in a systemic way, beginning with inflammatory causes, such as vegetative pyoderma gangrenosum or dissecting cellulitis of the scalp, tumoral causes, ciliandromatosis, cutaneous lymphoma, hematologic malignancies, or infectious causes such as atypical mycobacteria, bacteriomycosis, actinomycetoma, actinomycosis, fungal mycetoma. So we ran some tests, and all came back negative except of a mildly elevated CRP. So normally, what a dermatologist will do, he will do a biopsy. A skin biopsy was performed, and it showed an ulcerated epidermis with underlying neutrophilic microabscess surrounded by granulation tissues consisting of plasma cells, macrophage, and fibroblast infiltration. And sulfur granules were found at the center of the inflammatory process with filamentous basophilic radiating fungal-like structures. So the skin biopsy was cultured, and culture was positive for actinomyces miri. And the diagnosis of primary actinomycosis of the scalp was retained. So what's actinomycosis? Actinomycosis is a rare chronic progressive disease that was first described in 1878, and it is characterized by abscess formation, draining sinus tracts, fistula, and tissue fibrosis. What causes actinomycosis? It's a bacteria called actinomyces. It's an anaerobic, not acid-fast, filamentous, gram-positive bacteria, and it was initially misclassified as fungal because it is filamentous, hence the name actinomycosis. Actinomycosis are part of the normal flora, and they are unable to penetrate healthy skin. In order to become invasive, the barrier must be disrupted. The most common sites are cervicofacial, abdominal, thoracic, but it can also be cutaneous in some cases, like the case of our patient. So biopsy is important for diagnosis since it might show granulation tissue, sulfur granules, and filamented bacteria. However, the gold standard test for diagnosis is bacterial culture. Treatment is prolonged antibiotics. These are my references, and thank you.
Any questions? I have a question for you. I mean, if a patient presents with this clinical picture, I would not be doing any blood work. I would start with a biopsy, I think.
Yeah, but we didn't see the patient first.
Okay.
The patient was seen by internal medicine.
Okay. Thank you.
Yes, I have one more question. I think the third person has a question.
When the cultures were done initially, you included both anaerobic and aerobic culture? Both anaerobic and aerobic culture were ordered initially?
Yes.
And what prompted you to do anaerobic?
The atypical lesions on the scalp, because in the differentials was either mycobacteria or some germs that will take long time to grow or that need some specific medium.
Okay, thank you.
Sorry, one more question. Any predisposing factors for this patient?
No. Normally, to have this kind of infections, we have some trauma to the head, some point of entry, but the patient didn't have any. And the CT scan of the brain was normal and no bone lesions.
Maybe the barber then?
Maybe.
And why did you give the patient just oral penicillin and not intravenous penicillin?
No, he took 6 weeks IV amoxicillin, then PO.
Thank you very much. Thank you. Interesting. Okay, we're into infections now. So our next speaker is Dr. Hassa El-Mazroui, and her title is Opportunistic Infections.
Assalamu alaikum, everyone. My name is Hassa El-Mazroui. I'm a first-year resident, and today we'll be talking about the resurrection of an ancient scourge, nodules and HIV. So my patient is a 34-year-old male who is a known case of HIV. He presented with a 2-month history of a widespread itchy rash. It started as a few raised lesions on his trunk, which then spread to his scalp, to his face, as well as the genitalia, and covering almost his whole body. So review of symptoms was negative. He is diagnosed with HIV since 2021 on antiretroviral therapy. He is divorced and denies sexual contact. There is no recent history of travel and no known allergies. So on physical examination, his vital signs were normal. He presents with this erythematous papules. Some were ulcerated. The largest one was about 3 centimeters inside. Some had central hemorrhagic crust. Some were umbilicated, and they were in a generalized distribution. We can also appreciate the wart-like lesions on the nipples. He had erythematous annular papules with scales covering his arms, and they spread down to the palms as well. He had 2 nodules with yellowish crust in the medial aspect of the eyebrows, and actually after 10 days he came back to the clinic, and we can appreciate that it has increased in size. They are now touching each other. He also had firm immobile nodules in his scalp. So considering he's a patient of HIV, we had several different differential diagnoses, starting with giant molluscum contagiosum, deep fungal infections, secondary syphilis, Kaposi sarcoma, disseminated TB, eosinophilic folliculitis, and leishmaniasis. As for investigations, his HIV panel showed that he had good control of the disease of HIV with the therapy he was on. Viral screening as well as fungal culture were both negative. We were screening him for syphilis. We started with a treponemal test, which was reactive. He has no history of syphilis, and therefore we did a confirmatory non-treponemal test, the RPR, which came back non-reactive. We did the second treponemal test, the TPPA, which was reactive. We then spoke to the lab and asked them to check for the prozone phenomena to dilute the sample even further, which came back with a positive RPR of 1:64. As for his skin biopsy, we took a 4mm punch biopsy from the back, which showed psoriasiform hyperplasia of the epidermis with superficial, perivascular, and perifollicular infiltrate in the dermis. On further magnification, we can appreciate the hyperplastic epidermis and the infiltrate mostly composed of plasma cells, which are those eccentric nucleus larger cells. The silver stain, the Ziehl-Neelsen stain were negative, and the Werthenstein stain was positive for spirochetes. So with that, we come up with the diagnosis of malignant syphilis, which is a severe form of secondary syphilis. To treat this patient, we admitted him to the IDU for further workup. We ruled out all other causes of deep fungal infections. He refused a lumbar puncture, but a CT brain was done, which showed cutaneous syphilitic nodules. Neurosyphilis was ruled out at this point, and according to the CDC guidelines, he was treated with 1 dose of benzathine penicillin G. We also kept him under close monitoring for the Jarisch-Herxheimer reaction, which is known to be more prevalent in those who are immunocompromised at around 36%. We also gave him referral to neurology, cardiology, and ophthalmology. So upon follow-up, he presented 1 week after the medication was given. As you can see, the lesions have resolved with post-inflammatory hyperpigmentation, and they have completely flattened. We can also appreciate that the nodules in his eyebrows have decreased in size, and he agreed to repeat the RPR every 3 months for the first year and at 24 months. So this is an illustration from the 1800s. Syphilis in the pre-antibiotic era and in the ancient textbook is thought to be a dreaded disease. However, with the discovery of penicillin in 1928, we started to see the less severe forms. However, with the HIV pandemic, this ancient scourge is coming back to haunt us. We can also see from the CDC graph that in the past few years, syphilis rates have been increasing, so it's important to keep it in our minds. Considering that HIV patients represent a special population that defines the clinical norms of co-infections, sometimes diagnosing these patients could be hard as presentations could vary, so it could pose a diagnostic challenge. This is a systematic review of 45 case reports, which showed that the most common frequent lesions seen in these patients were ulceronodular lesions with adherent crust, similar to that of our patient. However, there are some case reports out there with different presentations, such as this one from the BMJ, which presented with a very deep, painful, non-healing ulcer in the gluteal fold. So the physicians could use the Fisher's criteria to help aid in the diagnosis of malignant syphilis, which includes compatible gross and microscopic morphology, a high titer for syphilis, the Jarek-Herxheimer reaction, and a dramatic response to antibiotic therapy. 3 out of them which our patient had. A biopsy is also warranted to rule out other manifestations. So for my take-home point, syphilis is an ancient disease in which we thought we conquered with antibiotics. However, it resurfaced to its more aggressive forms, specifically in those who are immunocompromised. It's important to be aware of the proson phenomena to rule out early neurosyphilis, and as always, an interdisciplinary approach is best for our patients. Here are my references, and thank you very much.
Okay, our next speaker is Dr. Khalifa El-Mehiri, and his case is going to be a case of a single nodule in an infant, molecular warfare from a remote rival. Interesting.
Assalamu alaikum. So, I'm Khalifa El-Mehiri, dermatology resident from Rashid Hospital. So, the title of our case today is a single nodule in an infant, a molecular warfare from a remote rival. So, our young patient is a 5-month-old Emirati female presented to our clinic with a single nodule on the forearm of 2 months duration that was showing recurring changes in color and size. So it was located in the dorsal aspect of the left forearm. It started as a skin-colored papule, changed to a light brown nodule. It was associated with frequent biting and rubbing of the lesion, which resulted in frequent, in occasional redness and blistering of the lesion as well. So, quick history, she had intraventricular hemorrhage at age of 2 months due to deep vena thrombosis diagnosed from the pediatrics, so pediatric team was on board with us also. She had 1 episode of syncope at age of 3 months. She had repeated episodes of flushing from age of 4 months. It was precipitated by crying, hot bath, and lesion rubbing, as the mother reported. Also, there were vomiting and diarrhea, which was accompanied with abdominal pain and irascibility. So, patient was born at 38 weeks to non-consanguineous parents. She had cow's milk protein allergy. However, the drug and family history were not significant. Proceeding to the examination, patient is vitally stable, alert, but she was anxious. For the dermatological examination, as you can see, a well-demarcated 7 to 2.5 centimeter nodule, pink to skin colored with peripheral hyperpigmentation. As you can see, there is also a pseudo-orange appearance on the surface, few erosion and crusts. By palpation, it was non-tender and had leathery to rubbery consistency. Systemic examination is unremarkable. Our differentials for today are mastocytoma, persistent insect bite infection, juvenile xanthogranuloma, and tuberous xanthoma and keloid. So we had a provisional diagnosis in mind. So we proceeded with stroking, or we stroked the lesion with a tongue depressor. Within 3 minutes, lesion and perilesional skin were edematous, erythematous, and itchy, which demonstrated a positive diarrheal sign. So facial flushing also was prominent. By investigation, imaging revealed subcutaneous lesion. Labs were not really conclusive for something. It was most of the labs results were within normal limits. However, the eosinophils was on the normal side, on the lower side. So the pediatric team, they requested a genetic test regarding the intracerebral hemorrhage and was positive for factor 2 homozygous. So skin punch biopsy done, and the upper dermis, as you can see, mostly showed sheets and nests of oval to polygonal cells with round to oval nuclei along with the scanty eosinophils. Immunohistochemistry also, CD117 positive in mast cell. So thus we reached to a diagnosis of solitary mastocytoma. So as per the management, patient's parents were educated and reassured. Leaflet was given to avoid mast cell degranulation stimulants. As you can see, the table has some classic examples of the stimulants. Topical potent steroids under occlusion and oral antihistamine for the systemic symptoms. So as we know, there is a history of syncope and risk of anaphylaxis. So a peripheral injection was given to parents and surgical option was also offered. There are no published cases reported both a mutation, c-KIT mutation and factor 2 mutation in one patient. For the discussion, mastocytosis, a rare heterogeneous group of disorders characterized by abnormal proliferation and accumulation of mast cell within the skin and or other tissue. Mainly it's caused by KIT mutations. It's broadly divided into systemic and cutaneous mastocytosis. So mastocytoma in our case account for 10 to 15% of cutaneous mastocytosis. It's good to note that mast cell is a critical cell and dangerous as well. It can lead to anaphylaxis within seconds of stimulation, also as well as other diverse physiologic effects as described in the table. So our take clinic notes for today is that dermatologists shouldn't underestimate extracutaneous feature. A positive Derrier sign in mastocytoma is a reliable sign. Solitary mastocytoma in infancy tend to resolve spontaneously before puberty, and the risk of anaphylaxis in cutaneous mastocytosis is lower compared to systemic mastocytosis. These were my references. Thank you so much for listening.
Good morning, everyone. My name is Khulud Al-Marzouqi, and I'm a third-year dermatology resident from Sheikh Khalifa Medical City. And today I'll be sharing a challenging case that serves as a reminder about our roles as dermatologists, which can sometimes extend beyond the skin, especially when dealing with patients of delusional infestation.
Khulud. Bring the microscope close.
Okay. So as we know, delusional infestation is a rare disorder. However, recent studies have shown its growing frequency, where it's expected that dermatologists would see between 1 in 5 patients with delusional infestation annually. However, despite this increasing frequency, each patient presents with its own set of challenges. So just like no two minds are identical, there is no uniformity in the presentation of such patients. So this brings us to our patient. This is a 40-year-old Iraqi female that presented with a complex overlap of delusions, which we're going to be seeing shortly. But the complexity of the case was much deeper than that and lied in several key aspects. The first to consider when seeing such patients is doctor hopping. So patients with somatic delusions often embark on a medical journey in efforts to find an understanding, just like explorers navigating a chain of multiple visits. So you might be their first encounter, or you might be a link in a multiple chains of visits. So it's very important as healthcare professionals is not to have any aggression against the previous physicians who have seen the patient and probably treated her for the infestation. And the second is not to be impatient and to refer her immediately to psychiatry. So the story started 4 years ago. She was having a walk along the beach in Jordan where scabies entered her skin from her feet. She then described as generalized itchy skin lesions with insects crawling out of her skin. It's present all the time. She can also see and feel the scabies crawling in her mouth, ears, between her fingers, and on her eyelashes. She now believes that it's in her blood and urine, and also it causes her teeth to fall out. She also mentioned that she sometimes sees fibers emerging from her skin. She denied any family members with similar lesions, and she was seen by multiple dermatologists in the past and was treated with multiple courses of permethrin. In efforts to get rid of the infestation herself, she would take daily baths with bleach. She has difficulty sleeping, it's affecting her quality of life, she lost her job as well. She denied any recent medication use, and past medical history and psychiatric history was also unremarkable. Moving on to the imaginary pathogens. Now, as we know, humanity has always been concerned about infections and infestations, having gone through ancient plagues in ancient history, as well as viral pandemics in our time. Just like that, patients with delusional infestation have those exaggerated fears of infections and infestations that have been stable over time, but interestingly, there has been a shift in the content of the delusions. So when it was first described in the 19th century, it was mostly evolved around scabies, typhus, pests. Slowly, this changed into microorganisms like viruses, bacteria, and parasites. And now, in our time, in the 21st century, we have emergence of inanimate pathogens like hair strands, threads, and fibers, so-called as the Morgellons disease, which has caused controversy. So the patient had an overlap of both, the classic scabies, which could be a realistic infestation, hence why she was treated with multiple courses of permethrin. On the other hand, fibers could be difficult to medically reason with the patient because it's unrealistic. Moving on to the workup and the results. Usually patients with delusional infestation would always ask for a more comprehensive and definitive diagnostic workup, no matter how many tests they've done in the past. Just like that, our patient, we've done a comprehensive investigation workup, including the labs shown on the slide, as well as urine toxicology and skin scraping, which was all non-contributory. But even with the negative results, the patient was not relieved. She kept on insisting that she sees those insects crawling out of her skin. And when she pointed to them during examination, we had a look under the dermatoscope, and it turns out to be just hair fibers and tufts of threads. Not only that, she provided us with a pickle jar, basically, with her hair extension in it, so-called as the specimen sign. So we did examine it, and we told her that we couldn't find any scabies or any eggs. She also provided us with a water bottle for which she collected scales from her hands and feet and placed them in a tissue paper and then in the water bottle for us to also examine. Moving on to the internet. So while the internet can provide us a valuable resource and access to many information, as well as formation of communities with people with shared experiences, this can be dangerous for patients with delusional infestation as it forms this cycle. So it facilitates self-diagnosis. So after the emergence of Morgellons disease in 2002, there is a website called morgellons.org where it explains what the disease is. Patients share their experiences in this website as well. So patients can have a look through those websites and can align it with their own symptoms and hence further strengthens their conviction of being infested. Not only that, they can have access to communication with healthcare professionals. So there is actually annual conferences going on Morgellons disease where physicians, nurses, patients who have Morgellons disease would gather around and discuss about the disease. So formation of online communities, they form rallies. So it gives a sense of support and validation for such patients. I found a few interesting comments from different YouTube videos, and one of them says that anyone who believes that Morgellons is a delusional disorder should be sued and they should lose their license. So moving back to our patient, so she had access to the internet, so she looked for alternative therapies, but all what she did was just an exaggerated form of everything. So she would take daily baths and bleach. She would not sleep on any mattress in fear of infestation, so she sleeps sitting on a couch literally every night, which affected her quality of sleep, and she would discard any clothes that she would wear once. On examination, we can see the consequences of the use of bleach. So she had bilateral eczematous patches as well as kind of fissuring. Now, in her mind, she thinks that those skin changes are due to the scabies rather than the use of bleach. Moving on to the final big challenging reveal. So after thorough assessment and discussion of the treatment plan and referring her to the psychodermatologist, the patient went to the pharmacy to get her prescription of risperidone. She returned to us to the clinic and revealed that her mother was actually taking the same medication. We were all surprised, and when we asked her why did her mom take the medication, she mentioned that her mom also had a history of delusions of hypochondriasis. So she mentioned she would always go to different physicians. She would always think that she has cancers. So we sat with her, we counseled her for a long time, and then we agreed that we're going to start for 2 weeks on risperidone and we're going to reassess her. However, she flew back to Jordan and ultimately she lost follow-up. So this brings me to the end of my talk. I just want to emphasize that although delusion of infestation is primarily a psychiatric disorder, but usually, or more than 90% of the cases actually present to dermatologists and other healthcare professionals. So it's very important for us not only to be able to identify this disorder, but also to anticipate the challenges that might be encountered with it. Thank you.
I invite Dr. Namira Liqam for her case presentation from a dermatopathologist point of view. Welcome, Dr. Namira.
Good morning. Recently I have done my rotation in dermatopathology with Dr. Reem Bahtami. I have encountered a very interesting case. I would like to share it with you, but we're going to do it from a dermatopathologist point of view. So we're going to go through a ride. So starting, as a dermatopathologist, we look at the slide blindly. So as you can see in this slide, we have a raised papule of the skin covered by the epidermis. The content of the papule was fibroblasts, foamy histiocytes, and two-tone giant cells with variable inflammation, including eosinophils and RBC extravasation. So looking just as the slide, the first diagnosis we have in mind is a xanthogranuloma. But let's look at the clinical history. So our patient is a 33-year-old male, Middle Eastern. He came with a 1-year history of a red yellowish flat group of papules, plaques over the sides of the chest, lower back, armpits, with a normal lipid profile, and he was non-diabetic. So we contacted the dermatologist, and of course we asked for the clinical photos. So as you can see, he has xanthelasma over the bilateral upper and lower eyelids, brown to red papules over the bilateral sides of the trunk. So our differential diagnosis at that point included Erdheim-Chester disease, indeterminate cell histiocytosis, necrobiotic xanthogranuloma, and generalized eruptive histiocytosis. The next step was to do immunohistochemical stains, and as you can see, our patient was positive for CD68, negative for CD1A, and negative for BRAF. So going back to our differentials, generalized eruptive histiocytosis, we won't see in the biopsy two-tone giant cells, and we would see minimal to no lipidized histiocytes. In necrobiotic xanthogranuloma, we would obviously see necrobiotic collagen and abundant cholesterol clefts. In the intraderminate cell histiocytosis, the patient will have S100 positive and C1a positive, which was negative in our case. So going back to our first differential, which was Erdheim-Chester disease, as in our patient, they would have eyelid upper and half of the body. They would have red-brown to yellow indurated plaques, and they would have CD68 positive and CD1a negative. So we reached our final diagnosis of Erdheim-Chester disease. What we did is we informed the dermatologist, and systemic investigations including bone CNS was recommended. Unfortunately, the patient was referred to an oncologist, but he lost follow-up, so we don't know if he went through the investigations or not. So moving on to the discussion, ECD is a rare condition characterized by abnormal accumulation of histiocytes in various organs. It's considered one of the rare forms of the non-Langerhans histiocytosis. Approximately 25% exhibit dermatologic manifestations, which can serve as an important diagnostic clue. They present with the xanthelasma-like lesions, which are often symmetrical, pseudosclerodermatous involvement, and erythematous to brown papules or nodules. Less common manifestations include purpuric lesions, lividia reticularis, and subcutaneous nodules. They can also present with fever, bone pain, exophthalmos, diabetes insipidus, involvement of the lung, kidney, adrenal, heart, and CNS. But some cases would present with asymptomatic lesions, like our case, and some others would present with multisystemic, light-threatening form. These patients have poor prognosis. It's diagnosed with histologic analysis. The typical pattern is a polymorphic granuloma infiltrated with CD68 positive and CD1a negative, foamy histiocytes, fibrosis, or xanthogranulomas. These histiocytes may be found almost in any tissue in the ECD. Treatment is symptom-specific and temporary with surgical debulking, corticosteroids, interferon, chemotherapy, radiation therapy with varying degrees of success. So my take-home message is two things. First of all, don't forget about Langerhans histiocytosis whenever you see a patient. Second of all, please send your dermatopathologist pictures. It will save you and us time. Thank you.
Good morning, everyone. So today I will be presenting a case of dupilumab-induced psoriasis in a patient with atopic dermatitis treated previously with cyclosporin. So it is a case of 22-year-old male patient known to have atopic dermatitis since birth, uncontrolled on many topical treatments, with a family history of atopic dermatitis, presented for a severe atopic dermatitis flare-up with thick erythematosquamous and yellowish crusted plaques, mainly on the face and neck, but also on the dorsum of the hands, arms, antecubital fossa, upper back, trunk, and lower limb. And he has an EASI of 14. So those were the plaques on the face, on the neck, arms, hands, and antecubital fossa. So cyclosporin was introduced, and we can already see the improvement on day 36. So after 6 months on cyclosporin, he achieved an EASI 90, and since it is a short-term treatment, it was switched to dupilumab. 2 days after dupilumab, the patient started having a mild exacerbation with the reappearance of scaly plaques. And then, on day 18, he had a severe exacerbation with the thickening of the scaly plaques on the face, neck, upper back, and trunk. And this was on day 20. So after this severe exacerbation, cyclosporin was restarted and a biopsy was taken. It showed parakeratosis, thinning or even absence of the stratum granulosum, acanthosis with enlarged rete-ridges, mild spongiosis and lymphocytic exocytosis in the basal layers, and perivascular inflammatory infiltrate in the superficial dermis, mainly lymphocytic, so it was more compatible with psoriasis. After the result of the biopsy, baricitinib was introduced. He had a very well improvement, but with the persistence of some lesions on the arms. So we switched to upadacitinib, on which he had a very marked improvement. So dupilumab, it is a fully human monoclonal antibody. It blocks the interleukin-4 receptor alpha, which is the common alpha chain of interleukin-4 and interleukin-13 receptor. So it will inhibit the interleukin-4 and 13 signaling, blocking therefore the Th2 signaling pathway, which is the main pathway in the atopic dermatitis. So as the use of dupilumab expands, we have more case reports suggesting unreported cutaneous side effects, such as new onset psoriasiform dermatitis. In fact, interleukin-4, which is one of the main cytokines of the Th2 pathway in atopic dermatitis, is a negative regulator of Th1 and Th17 cells. It can modulate the phenotype of dendritic cells, leading to the suppression of interleukin-23 production. So blocking interleukin-4 by dupilumab will cause an overproduction of interleukin-23 and interleukin-17. So we'll have a shift from the Th2 to the Th1, Th17 pathway, leading to psoriasis. In fact, in a case series done by Napolitano et al. From 90 atopic dermatitis patients treated with dupilumab, 3.34% had new onset psoriasiform eruption, from which cyclosporin was the most previously prescribed conventional systemic drug. In fact, in all reported cases of dupilumab-induced psoriasis, the mean incubation period was of few months, whereas in our case, it was of a short interval of 2 days. This could be explained by the fact that cyclosporin inhibits the production of cytokines by both Th1 and Th2 cells, but with higher selectivity toward inhibiting Th1 cells. So, we postulate that stopping cyclosporin will release the Th1 pathway, and then adding dupilumab will inhibit the Th2 pathway and lead to a shift from Th2 to Th1. So Th1 will be more potentiated, which will lead to a faster emergence of psoriasis. So as take-home messages, psoriasiform lesions can appear during effective treatment with dupilumab for atopic dermatitis, reflecting a shift toward Th1 pathway. Switching from cyclosporin to dupilumab can facilitate a rapid onset of psoriasis. The hypothesis is that the cessation of cyclosporin will release the Th1 pathway, which will be further potentiated by the dupilumab. And thank you.
Thank you, Dr. Raed. I invite Dr. Rokeya Al-Abri to give her presentation next.
So good morning, everybody again. I'm Rokeya Al-Abri, plastic surgery trainee from Khawla Hospital, Sultanate of Oman. And I'm excited to present a presentation titled Decoding Rare Scalp Mystery, a Unique Journey. This is the outline of my presentation. So we'll start with case presentation. We have a child which was born at 38 weeks to an 18-year-old primate mother, which is Rh negative, and she received anti-D. On delivery, vacuum trial attempt, then it's followed by low cesarean section due to placenta abruption. Patient was having scalp lesion, so he referred to our hospital. He reviewed by craniofacial team, and it shows that there is scalp lesion involving frontoparietal area. It was 8 times 5 centimeter with absent scalp bone midline around 2 centimeter, and surrounding skin was intact with mild redness. This is the picture of initial presentation. So initial plan was for conservative management and regular dressing. Patient also reviewed by wound care, and she advised for regular dressing with the new gel. MRI done at age of 6 days, and it shows aplasia cutis congenita with absent skin and subcutaneous tissue over the vertex. No bony defect, which was also confirmed by CT. Patient was stable in condition. He discharged after 1 week on regular wound care. And he was also on regular follow-up with plastic surgery and also with the wound care. And in follow-up, it shows that there is granulation tissue and signs of healing and contraction. And unfortunately, patient came to the emergency at 40 days of age, and it shows perfused scalp bleeding. Emergency department managed by pressure dressing. Patient shifted then to the OT immediately, and exploration and hemostasis of superior sagittal sinus, bleeding done. Findings of the surgery were defect in superior wall of superior sagittal sinus with active bleeding. And the defect actually was friable and irregular. It's sutured. Suturing was not done because of this. And it's covered with friable surgical cell and gel form and T cell. Pressure dressing applied. Then after 4 days, patient underwent wound inspection, dressing change, and the findings were raw area over superior sagittal sinus, as you can see here in the picture. The wound was large and approximately 5 times 5 centimeter with mild slough tissue, but no discharge, and good part of the wound was covered with granulation tissue. Then after 7 days, local transposition flap cover, and as you can see here, this transposition flap, and also split thickness skin grafting harvested from the right side of the patient. And this picture is on the dressing, on regular dressing, post-op. Patient kept on regular dressing, discharged after 37 days from the last surgery. And he also kept in regular follow-up with plastic surgery. This is the last visit of the patient. As you can see, it all covered. But he has area of alopecia. So patient planned for tissue expander at age of 8 to 10 years. So aplasia cutis congenita is a rare congenital disorder that results in the absence of area of skin at skin birth, and typically it's involved multiple layers of the skin, and less commonly it can involve periosteum and bone. First described in 1797 on twin sister with aplasia cutis congenita involving lower limbs. It's of unknown etiology, and though it seems multifactorial, genetic condition reported as autosomal dominant, autosomal recessive, and also sporadic. And most acceptable theories are conditions that can affect fetal development, like intrauterine infection, ischemia, poor blood supply, and neural tube defects. And presentation varied from solitary or multiple lesion. It presented as ulcer-like or trophic-like macule. Treatment usually conservative, but surgical intervention may need it. So our case is extensive case of aplasia cutis congenita involving the vertex of the skull and manifesting as 8 times 5 centimeter and bone defect over the frontoparietal region. Incidence it's rare. It occurs in 3 to 4 per million live pairs. The lesion depth variable can range from subtle subdermal scarring to full thickness exposing underlying structure like the sagittal sinus in our patient. Etiology is unclear. And mechanism like intrauterine trauma, vascular compromise, teratogenes, and genetic mutation can affect. And there is no definitive cause in our case, but failed vacuum delivery attempt could be a contributing factor. And this is a case report published in 2021. And it shows that, as we said, aplasia cutis congenita is a rare disorder, and mortality rate it's around 20%, resulting usually from association with meningitis bleeding and meningitis or bleeding in patient with skull cap involvement. And also, the causes could be distribution or failure of development of skin layer, including epidermis, dermis, and subcutaneous fat, and also in utero destruction of skin that might otherwise have developed normally.
Management,
Dr.
as we
Rukaya,
said,
you have run out of time. Maybe you want to summarize it?
sorry?
Your time is up, actually. Can you just give us the last slide?
Okay, sure. So this case is extensive case of aplasia cutis congenita, which could be exacerbated by vacuum-assisted delivery, which required multi-stage surgical management after spontaneous bleeding. So it's important to highlight severe manifestation of aplasia cutis congenita and to emphasize to monitor the exposure-related complication in conservative management. Thank you.
Hello everyone, good morning. My name is Sheikh Salah. Today I'll be presenting a case, but before I do, I would like to pose a question that says, is what is common actually common? So my patient is an 87-year-old male who has multiple comorbidities such as hypertension, diabetes, he's also hepatitis B positive, chronic kidney disease. He was admitted under geriatric medicine to undergo ERCP for gallstones. And that is when we got the call. We got the referral from geriatric medicine telling us that there is a lesion at the right cheek. And so when we went, this is what we found. We found an erythematous plaque at the right nasolabial fold. There was no discharge. It was not extending into the oral mucosa, and no lymphadenopathy was felt. And this is when we thought of differential diagnosis. So remember my first slide, I said what is common is common. This is when we thought of, okay, what could be the common differentials? And in a case of an elderly patient with a lesion on his face, somewhere where it is sun exposed, we thought of cancers. We thought of basal cell carcinoma, squamous cell carcinoma, maybe it's a melanoma, maybe it's a lymphoma. So guess what we did next? Actually, nothing fancy. We just did the biopsy. And this were the results. Basically, there were small round blue cells with high NC ratio, and it was seen to invade into the dermis. It was positive for cytokeratin and positive for synaptophysin. It was also positive for CD56, and it was negative for TTF1. This is when the dermatopathologist came back with the diagnosis of Merkel cell carcinoma. So talking a bit about Merkel cell carcinoma. Merkel cell carcinoma is a very rare disease, so it's not actually common, and it is highly malignant, and it has a very poor prognosis. It usually happens in elderly. Differentiating it from other types of skin cancers could be challenging. There are two pathways that could lead to Merkel cell carcinoma. One is through the UV radiation, and this is why it usually happens in the sun-exposed areas such as the face, the head and neck, the limbs. The other type of pathway is through the Merkel cell polyoma virus. A study made in University of Michigan wanted to understand the correlation between this virus and Merkel cell carcinoma. So they studied the genome of this virus, and they found a very small part called the small t antigen. So what they did is that they got some mice, and they started injecting this small t antigen into these mice. After that, they started noticing that these mice actually developed Merkel cell carcinoma. So yes, there is a link between this virus and Merkel cell carcinoma. What made our study extra special is that this patient was actually hepatitis B positive. And researchers these days have been trying to find whether there's a correlation between hepatitis B virus and Merkel cell carcinoma. So in our case, we can open up for future research to be done regarding this correlation. In conclusion, Merkel cell carcinoma is a very rare type of cancer. It's very highly malignant, and it usually happens in elderly. Now, if you were wondering what happened with our patient decided to follow up in private. However, the gold standard treatment for Merkel cell carcinoma is a wide local excision plus minus chemotherapy and radiotherapy. So going back to my first slide, my first question, is what is common actually common? So is squamous cell, basal cell carcinoma, the common types of skin cancer, are they actually common? And the simple answer is yes, and we should always keep the common diseases at the top of our differentials. However, always keep an eye on what's not. And in our case, it was the Merkel cell carcinoma. This is our case report. It is available online as preprint. You can check it out. These are my references, and thank you.
So good morning, I'm Dr. Sheikh Al-Kipri from Rashid Hospital. Today I'm going to presenting an interesting rare case that presented to us of a 13-year-old male from UAE. So basically this patient presented with a rash within 7 days all over the face extremities. But initially he developed a chronic cough, fever, weight loss, and diffuse bruising all over the body, where he was found to diagnose with acute myeloid leukemia after investigation by the blood and bone marrow. As we all know, before starting chemotherapy, we have to screen for TB. So we did a screening and he has found to be positive for TB, and the patient kept under TB medication. And the leukemia therapy was postponed here. So on his second month of treatment, surprisingly, his leukemia disappeared without any chemotherapy. So even repeated blood films and bone marrow biopsy showed resolution and curance. So here we put it under follow-up and on his TB medication. A month later, he came with a skin lesion that is aggressively progressed, started with a one spot on the neck and then all over his body within 7 days. As we can see, symmetrical violaceous purple round indurated plaques on the face, chest, arms, and thighs, measuring from 1 to 3 centimeters in diameter. So our differentials was leukemia cutis and Kaposi sarcoma, and of course we did an investigations. One of them is skin biopsy, and it showed for us a diffuse infiltrate of typical neoplastic cells with high NC ratios, and till here we are suspicious regarding his leukemia. So furthermore, we did an immunohistochemistry, which is my highlight of the day, to investigate and diagnose and confirm our diagnosis. So the neoplastic cells that we saw earlier showed a strongly positive for LCA, MPO, TDT, CD117, which is all suggest an infiltration of the leukemic cells, and this all toward our diagnosis of leukemia cutis. And in addition to Ki67, which is a proliferation index, which means that there is a proliferative cells over here. This is a closer look for the immunohistochemistry showing the uptake of the stain, CD117, LCA, and CD99. So this confirmed our diagnosis of leukemia cutis. As a management, patient transferred to Cincinnati Hospital in US, where he was cured with chemotherapy and no bone marrow or peripheral blood involvement at the time of skin relapse with leukemia cutis. So patient under continuous follow-up for any systemic relapse, and currently he is fully cured. Going to the discussion, dermatologists here play a vital role in diagnosis of leukemia cutis. And as we all know, leukemia cutis is the infiltration of the neoplastic cell in the epidermis, dermis, and subcutis that resulting in skin lesions. Head and lower extremities being the most common site of involvement, and AML, acute myeloid leukemia, with leukemia cutis is a rare with reporting incidence of 2 to 3%. This is probably due to the paucity of diagnostic facilities and the lack of awareness between the physicians. And this is why I'm presenting this case. AML is the second most common cause of leukemia cutis, and leukemia cutis typically occurring with the systemic leukemia, but this is not always the story. It can happen before or after or unrelated to the systemic. And the time from skin manifestation to leukemia diagnosis ranges from 1 to 12 months. Now, studies suggest that when leukemia cutis is present with acute myeloid leukemia, it is associated with aggressive disease and short survival. But thankfully, our patient was survived because of the early intervention and the diagnosis, of course. In addition to that, the CNS involvement of acute myeloid leukemia occur frequently in patients with leukemia cutis in 17%. This also indicates the aggressiveness of this disease if they came together. I mean the acute myeloid leukemia and leukemia cutis. And lastly, only few studies about leukemia cutis in pediatric population has been reported, and children often present leukemia cutis with the systemic leukemia, and it's more common with acute myeloid leukemia. Since the morphology and the distribution of leukemia cutis varies, physicians must maintain a high index of suspicions for this diagnosis, as the presence of leukemia cutis may change the management of systemic leukemia, and this is my highlight of the day. Lastly, studies emphasize on clinical, histopathological, and the stains correlation to confirm the diagnosis of leukemia cutis. And this is my references. Thank you.
Assalamu alaikum. This is Dr. Zamzam, dermatology resident from Oman Medical Specialty Board. So reaching to the last, hoping you are enjoying your time with us. So let's know what is behind the scene of our patient. So I have a 58 years old female patient who is a knowing case of acute myeloid leukemia. She failed chemotherapy and she was kept on palliative care. This patient was admitted in hemato-oncology department for treatment of febrile neutropenia. They called us to see the patient, and she presented with the sudden eruption of painful erythematous to violaceous papulonodular eruption over the both upper limbs. It was associated with high-grade fever. As you can see here in the examination, the lesions are more on the right forearm compared to the left. So our differential was, it is leukemia cutis. Is it vasculitis, nodular type? Is it inflammatory dermatosis like pyoderma gangrenosum or Sweet syndrome? And the infections like sporotrichosis, as well as the great mimickers, we add them. For that, skin bunch biopsy was taken, and as you can see here in lobar, there is dense infiltrate in the upper dermis. Coming closer, it's mainly neutrophilic, and there is marked RBC extravasation and numerous of histiocytes. And there was no features of vasculitis was seen in this biopsy. For that, also stains were done, and was markedly positive for myeloperoxidase stain, and was negative for CD34 and CD117. So by that, we ruled out leukemia cutis. So what do you think the histopathology report? It came as histiocytosis Sweet syndrome. So based on the clinical features and histopathology report, the patient was fulfilling almost all the diagnostic criteria of Sweet syndrome. So she was responding very well with topical steroid, then she was discharged home. After that, 1 week later, she was readmitted again with picture of severe cellulitis over the right forearm, and it was also associated with high-grade fever. During this admission, we were not being involved to see the patient, and the parent team managed her as a case of severe cellulitis with inquiry necrotizing fasciitis. But fortunately, they didn't do any debridement for this patient. She was managed with multiple lines of antibiotics, but without any response. But fortunately, she responded very well with short courses of systemic steroid from hematology department, hematology side, because they thought to prevent the HLH phenomena. So the patient again was discharged on stable condition. Then 10 days later, she was readmitted again with severe progression of the previous cellulitis, as well with new eruption over the dorsum of the left hand and the oral mucosa. Again, she was managed with empirical antibiotics with no response. At that time, they called us to see the patient again. And the presentation, it was totally different from our initial presentation. As you can see, it is mainly deep erythematous with overlying blisters and necrotic skin in the right forearm. As well as here you can see there is a violaceous on the left dorsum, as well as there is necrosis over the previous cannula site. So this represents pathology phenomena. Now the oral mucosa was very striking. She presented with the painful violaceous plaque over the tongue in the anterior aspect, as well as on the sublingual area. The extensive workup was done and it was positive for high inflammatory markers and negative for any infectious cause. And the soft tissue ultrasound, MRI, as well as bone scan, it showed deep inflammation reaching up to the bone and muscle. So our impression was this is a flare-up of sweet syndrome. So we managed her with a high dose of IV steroid, following by tapering dose of oral prednisolone for 1 month. This is how she was before starting steroid, and see how fast she responded very well to steroid. After 3 weeks, almost the lesion healed with hyperpigmentation and eschar tissue. And this is her dorsum, and look how it was after steroid. And this is the oral mucosa. See how the tongue almost cleared. So coming to the discussion and literature review, as you know, Sweet syndrome is acute febrile neutrophilic dermatosis. We have 3 subtypes. The malignancy associated with syndrome, it is associated with up to 80% with hematological diseases. So back to our case, as you know, we have major and minor criteria, and our case was almost fulfilling all the criteria of Sweet syndrome. And so far, there are different clinical and histological variants of Sweet syndrome. And in this case, our histological variant was histiocytoid, although it is rare, but it's commonly known to be associated with Sweet syndrome, and which is associated with hematological malignancy. What about the clinical variant in our case? What do you think? Is it bullous? Is it cellulitis-like or necrotizing? Those pictures are all from cases report. So our final diagnosis in this case is this is necrotizing Sweet syndrome with histiocytoid histology. This is similar case was reported recently in November 2022. Necrotizing Sweet syndrome is a new variant of neutrophilic dermatosis mimicking necrotizing fasciitis. It has a cyclic and high morbidity rate. Now the differences between necrotizing Sweet syndrome and necrotizing fasciitis is that there will be no infectious cause as it is in our case. It will worsen with debridement, in opposite to necrotizing fasciitis, which will improve with debridement. It usually has deep neutrophilic infiltrate and respond fastly to a steroid. Now, what about pyoderma gangrenosum? It does look the same as necrotizing Sweet syndrome. So are they the same entity? When I searched, I found that some authors, they consider the necrotizing pyoderma gangrenosum, which is the severe form of pyoderma gangrenosum with the severe inflammation, along with necrotizing Sweet syndrome, to be likely the same disease. And they categorize them as a distinct variant of necrotizing neutrophilic dermatosis. So very difficult to differentiate both diseases. Now, what about the oral lesion? Is it because of Sweet syndrome? So we have to think out of the box. Is it because of a trauma or a drug? Or is it because of advanced stage of AML? Or is it because of a Sweet syndrome? So oral manifestation can be seen in advanced stage of acute myeloid leukemia, and this is mainly because of thrombocytopenia. And the most common oral manifestation that was reported was gingival bleeding. I found only 1 case report of lingual hematoma in a patient with acute lymphoblastic leukemia. She developed severe lingual hematoma, but after seizure attack. So this is most likely trauma-induced. What about sublingual hematoma and Sweet syndrome? Oral manifestation is usually uncommon in a classical Sweet syndrome, but the rate is more when it is associated with malignancy, mainly 12% when it is associated with hematological malignancies. Now, the most common reported oral finding in Sweet syndrome was oral ulcers, but sublingual hematoma have never been reported. So coming to the conclusion, there is no history of a trauma in this patient, and she is not in any antiplatelet medication that known to cause sublingual hematoma, but the lesions didn't resolve with multiple platelet transfusion, but it has excellent response with steroid therapy, and this painful violaceous plaque appeared after only few days from the skin eruption on background of Sweet syndrome of the skin. So clinically, this is most likely related to Sweet syndrome. So by that time, by this, our case will be the first case report of this rare manifestation. Take-home message: necrotizing Sweet syndrome is a new aggressive variant mimicking necrotizing fasciitis. There are minimal cases reported in literature so far. A timely diagnosis allows for proper treatment and can reduce mortality. Always be aware and updated about Sweet syndrome and its evolving nature. Thank you.
Thank you, Dr. Zamzam.